Bismillah ar-Rahman ar-Rahim. I'm Dr. Saad Alharbi from King Khalid Special Hospital. I'm going to discuss with you in the next few minutes the indications for phakic implantable columnar lens with central port exchange or explantation in patients with or without keratoconus. The implantable columnar lens, ICL, is a type of phakic intraocular lens that is universally used for the correction of refractive error. The improvement in uncorrected visual acuity and the gains in the quality of life are significant patient motivating factors for considering such ICL implantation. ICL is also an important modality for addressing refractive error in patients with keratoconus, although irregular corneal astigmatism cannot be fully corrected with a toric ICL in many cases. It is still a reasonable alternative for correcting high myopic astigmatism in eyes with stable keratoconus, allowing partial visual rehabilitation. We examine the possible reasons for ICL, specifically type V4C, the new ICL with central port, in terms of exchange or explantation in keratoconus and in non-keratoconus patients from two tertiary care hospitals, which is King Khalid Eye Specialist Hospital and National Guard Hospital in Riyadh. All patients who underwent ICL exchange or explantation at both centers between January 2013 and January 2020 were included in this study. Eligible patients were then divided into two main groups: patients with keratoconus, the keratoconus group, and patients without keratoconus, the non-keratoconus group. A retrospective chart review was performed to evaluate indication for ICL exchange or explantation. During the study period, which is 7 years, 2,283 cases of ICL, specifically the V4C with central port implantation procedures were performed in both centers. 46, which resemble 2% of the explanted cases, required exchange or explantation. This means that 98% of the cases does not need the explantation or exchange. This is the results of our study. You can see that around 70% of the cases was among the non-keratoconus group. The age was same, the mean age, which is 32, and the time before ICL exchange was earlier in keratoconus group. There is no much difference in the gender, specifically in non-keratoconus group, and the surgery in terms of exchange or extraction was the same, 50-50 in the non-keratoconus group, while it is more in terms of extraction rather than exchange in the non-keratoconus group, which is around 64% of the cases in the keratoconus group. Interestingly, the endothelial cell count loss is not significant. As you can see, the rate of loss is almost the same after exchange or explantation, and there was no loss of best-corrected visual acuity in the non-keratoconus group, but there is one line loss of best-corrected visual acuity in the keratoconus group. The main reason for ICL exchange or explantation in both groups were the volt, and specifically high volt, which is more true in case of the keratoconus, while other causes of explantation or exchange was cataract and elevated intraocular pressure in the non-keratoconus group, and refraction and satisfaction in both groups. In conclusion, ICL implantation results in predictable refractive outcome over the long term with exchange explantation rate comparable to previous literature. Although improper volt size was the most common cause of ICL exchange explantation among patients with and without keratoconus with tendency toward high volt, especially in the keratoconus patients. This study highlights the need for more accurate methods to calculate ICL size to avoid incorrect fault measurement. Thank you.